Hey guys, Miss Hill here. Welcome back to Individual Module 5.1, PowerPoint 3, Lecture number 2. And this is the second half of PowerPoint 3 that we're talking about now, and we're moving into assessing fetal and maternal health. Some of these things we have already discussed in previous PowerPoints, so we'll do some review and then we'll add in some new things. And here we go. Our desired outcome, which we talked about at the end of PowerPoint 3 Lecture 1, is a safe pregnancy and delivery. We need a positive outcome for both mom and baby plus the family unit. In this field of work, that is our ultimate goal. Healthy mom, healthy baby. And so just a quick review of your nursing process. You guys should be so familiar with this now at this point in the program, but just in case you need a slight refresher, here it is. We got to do some assessing. We got to gather data. We got to analyze all that data. We got to identify the problem. We got to come up with some nursing diagnoses. And then we got to plan. We got to write some kind of care plan so we can meet our goals. So in the planning period, we got to set those goals, and then we got to figure out how we're going to accomplish those goals. Then we got to implement. We have to carry out our plan, and then we want to evaluate because we need to determine how well we met the goals that we set for our patient. Did we achieve our desired results? So here are a few nursing diagnoses that you might come across in this particular setting when we're assessing maternal and fetal health, health-seeking behaviors, knowledge deficit, risk for injury, maternal and fetal, anxiety related to diagnostic and test results, risk for ineffective coping related to unplanned pregnancy. I mean, there are just a ton. So, taking it back to the beginning, all the way to health promotion, we got to make sure that we're promoting health before pregnancy even starts. So, thinking to the beginning of this PowerPoint 3, when we talk about nutrition, folic acid to relieve, to prevent neural tube defects. So, preconception counseling, whenever we need to make sure that our lady needs to have the knowledge to avoid certain foods, or she needs the knowledge to avoid things like cat litter, knowledge about STDs. All of these things fall into preconceptual counseling and health promotion. We need a good health history, a good pelvic exam, and a pap smear test, and then labs, which we've talked about, all those prenatal labs that pregnant women get, the CBC, the type and screen, GBS, rubella. All of those are very important for health promotion from the standpoint of the mom and some from the standpoint of the baby. So what's your role as the nurse during health promotion whenever we're talking about a pregnant person? You are the database collection. Well, we don't answer numbers we don't know around here. Okay. I don't even know where 515 area code is. All right, so the role of the nurse. You are the database collector. You collect information so that we can make sure that we are assessing all aspects of this person to promote a healthy mom and a healthy baby in the end. We monitor fetal and maternal well-being through our different testing methods and our different assessment methods. We assist in screening tests if these moms need them. We educate related to their pregnancy, related to lactation, breastfeeding. We educate them about the newborn, how to take care of it, and we listen to them and we counsel them based on the data and the assessment findings that we come across. So here are a few things that you gather in your maternal assessment. We have to do an initial interview and a health history. We collect their demographic data. We talk to them about their chief concern. We gather their medical history data, past and present. We want surgical history, reproductive history, and gynecological history. It's important to know about any surgeries, any things that they've had going on reproductive-wise, their gynecologic history, STDs, any type of pap smears, surgery on their cervix. All of those things are very important when we're doing a maternal assessment. A comprehensive physical exam. We need that baseline set of vital signs. Remember, blood pressure changes during pregnancy. It changes during that second trimester and then returns back to normal in the third trimester. So we need a good baseline. We need a good baseline for height and weight. Why? Because we need to know how much weight mom is gaining, because it's a predictor of, can be a predictor of fetal weight gain as well. We want to keep them as healthy as possible. You got to do that complete head to toe on everybody. Pelvic and rectal exams, the doctors do those. And then there are those laboratory tests again. So for the fetal assessment, how do we accomplish this? Well, we do McDonald's measurements, fundal height measurements. That helps tell us how well the baby is growing approximately. We do fetal heart tones or fetal heart rate. And we can look at ultrasound results to determine if there are any physical or congenital anomalies, to look to see how well they are growing. We can do measurements of amniotic fluid pockets, whole bunch of things that we can assess fetal well-being with the biophysical profile through an ultrasound. And where are fetal heart tones supposed to be? What should our baseline be at with a fetal assessment? We should expect that we're getting a fetal heart rate somewhere between 110 and 160. Back to the slide real quick. I believe that your book says 110 to 160. Some places you will hear people say 120 to 160. So somewhere between 110 to 120 all the way up to 160 is where you should find your fetal heart rate baseline. Here are all those different types of laboratory assessments. We have talked about these in previous PowerPoints, so we're going to go through them again really quickly as a review. We want a CBC on all moms, type and RH, the rubella titer, the VDRL and the RPR, which is the syphilis screening, blood glucose monitoring, the MSAFP, that's the maternal serum alpha fetal protein. We get that somewhere between 16 and 18 weeks. Now that is an option. It's not required. So the doctors ask if mom wants that. It helps to tell them if there are any kind of abnormalities in the fetus. Not everybody gets it, and it's not a diagnostic tool. It's an assessment to determine whether or not we need to do further testing. So it detects abnormalities, but not specific abnormalities, if that makes sense to you. An indirect Coombs test, that has to do with the maternal and fetal blood types, hepatitis B titers, HIV screenings, serum drug levels for those seizure meds that we talked about, or any other kind of medications that require monitoring. Our oral glucose tolerance testing has to be done. And then we do urinalysis and we do dipsticks. First morning samples are best for detecting HCG, which is the pregnancy hormone, protein, and bacteria. And then also, we do this to look at glucose. And remember, we said a trace amount is okay, but we have to watch it closely. And we can also look for ketones in urinalysis and dipsticks as well. TB screenings can be added in. Good gracious. Vaginal smears for our chlamydia and gonorrhea testing, and then the group beta strep smear between 35 and 37 weeks. And we can also do genetic screening for ethnic groups that are at risk for things such as, things like sickle cell. So, there's also something that we do called a quadruple screen test. And this can be done to determine risk for certain birth defects. It measures 4 pregnancy hormones, and get your pen out and write these down, okay? So, quadruple screen test measures 4 pregnancy hormones. It measures AFP, or alpha fetal protein, and that's produced by the baby. It measures HCG, which is the pregnancy hormone produced in the placenta. It measures unconjugated estriol, which is produced in the placenta and by the fetus. And it measures inhibin A, which is a hormone released by the placenta. And this quadruple screen test determines risks for certain types of birth defects. It's a common one that is done, so it's one that you need to be familiar with. All right, what if we find any of these particular things? Okay, so if we have a hemoglobin and a hematocrit, it's 11 to 32. Do we have hemodilution? We've got hemodilution versus true anemia. We've got to be able to figure that out. Remember that whenever you are pregnant, your cardiovascular system increases its plasma volume by about 50%, and then red blood cells only increase by somewhere between 18 and 30%. So we have a discrepancy in the increase of those two things, which put pregnant women at risk for that false anemia. That lab work shows the difference in that hemoglobin and hematocrit ratio, and you got to be able to determine whether we're dealing with a hemodilution, which would give you a false anemia reading, or if what we're seeing is true anemia. Indirect Coombs. If it is positive, then we do not give RhoGAM to these people, okay? So if the indirect Coombs is positive, it means that the body is already sensitized to that blood from the baby. So what this test does, is it detects antibodies in the blood that would bind to the red blood cells in the fetus. So if it's positive, that means that there are antibodies there, which means that the mom has already made antibodies against this baby. So we would not give her RhoGAM, okay, because that's not going to do any good. Rubella titer less than 1 out of 10. That means that the mom needs to receive the MMR vaccine postpartum so that she can prevent, so that she can be immune for any of her subsequent pregnancies. So if the titer is less than 1 to 10 for rubella, that means that the mom is non-immune. Okay, if it's greater than 1 to 10, that means she is immune and will not need the vaccine. All right, so anything less than 1 to 10, we want that mom to have the vaccine after she delivers. And why can she not get it during pregnancy? She cannot get it during pregnancy because MMR is a live vaccine. An abnormal maternal serum alpha-fetoprotein, like I told you, this just detects that there is some kind of abnormality there, but it does not tell you what kind it is, so this person would need further testing. Positive smears, such as positive chlamydia or positive gonorrhea, these people are going to need some antibiotics. We want to clear up any type of sexually transmitted disease, any type of infection. GBS, we want to give antibiotics during labor. So anything positive like that, we want to treat with antibiotics to prevent any harm coming to the fetus. Positive HIV, these guys got to stay on their antiviral drugs. It is necessary during pregnancy to prevent infection in the fetus. It is very highly, it's been proven that if people stay on their antiviral drugs, that the fetus is much less likely to be positive for HIV. So we really want moms to stay on top of taking those drugs. And remember that a fetus can test positive for HIV initially due to the mom's circulating HIV antibodies, but eventually they will disappear if the baby is negative. So that's also important to remember when you're working in a nursery setting. Urinalysis, if that's positive, if it's just a trace of sugar, we don't panic. It's going to be all right. We just monitor her a little more closely. If she is positive for things such as ketones, then we may want to start, or protein, we may want to start looking at doing some additional testing for blood sugar and blood pressure issues. The reason that we screen for all these high-risk factors is so that we can avoid complications during delivery, during pregnancy, and during the postpartum period. So very important to catch these things up front and do some health promotion if possible, treat these issues if we find them, and prevent any type of bad things from happening during the pregnancy, during the delivery, or afterwards, because our outcome, our desired outcome, is a healthy mom and a healthy baby. So, during our ongoing prenatal visits, these are the things that we look for. We do a health interview. We discuss and we address their concerns. We do a physical exam. We check their weight every time. We check their blood pressure every time. And we do a urinalysis every time, looking for glucose, protein, ketones, leukocytes. And if we need to, we'll culture that urine. For whenever we're reviewing fetal health at these prenatal visits, the things that we do is we look at fetal heart rate, we check movements, we might do an ultrasound, we do McDonald's measurements, and always, 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 at every encounter you have with a patient, we are doing some type of health education and counseling with that individual. So, when do we see these people for their prenatal appointments? Well, this is kind of a breakdown of how it goes typically if you're not having problems. So when's my next appointment? Well, all pregnant people have an every 4-week appointment until they are 32 weeks pregnant. Normally, the physician's offices will not see you until you are at least 8 to 12 weeks pregnant. So they begin their prenatal visits around 8 to 12 weeks, and then they go every 4 weeks until they are 32 weeks. At that point, we need to start seeing them a little more often. So we see them every 2 weeks until they are 36 weeks pregnant. And then at 36 weeks, we're getting pretty close to delivery. So we want to see them in the office every week until they go into labor and deliver. However, this is only if mom and baby are not having any problems. If mom and baby are having problems, we will schedule them to come in as often as necessary. So, think about that as well, not just in terms of physical problems, so things like blood pressure, glucose screenings. Think about that also in terms of social issues. So the mom who is having signs and symptoms of depression, or even issues with the baby. Let's say she's having some decreased fetal growth. Maybe McDonald's measurement isn't coming out to what it's supposed to be at that point in time, gestationally. We can bring mom back as often as necessary, not just because of physical ailments or physical issues that might be going on, but also for emotional and social ones. We just want to stay on top of anything that might affect the desired outcome, which is healthy mom, healthy baby. Danger signs. We've talked about vaginal bleeding already, and we said there are a few things that can cause vaginal bleeding. Abortions or miscarriages, placenta previas, and placenta abruptions. So know those 3 things. Vaginal bleeding during pregnancy is not normal. So that is definitely a danger sign. Persistent nausea and vomiting, because we can disrupt the electrolyte levels for mom, which can ultimately cause cardiac issues. But even before then, we end up with nutritional deficits that affect the growth of the baby, and then we can end up with intrauterine growth retardation or restriction, or IUGR. Fever and chills, that's a danger sign during pregnancy, because that's telling us there is an infection somewhere, and we do not want moms to experience any types of infections that can ultimately move on to the fetus and affect the baby. Fluid leakage, so moms who have rupture of membranes early, or they're leaking some kind of fluid from their vagina, that's not a normal sign if it's too early. This could be a portal of infection for her if her membranes are ruptured, and it can also indicate that preterm labor is about to happen if it is prior to a term gestation. Abdominal pain. Remember, with that vaginal bleeding, especially if you're having that rigid abdomen and the patient's complaining of abdominal pain, the first thing you should think of is abruption, placental abruption. However, it can also mean that there's some preterm labor going on and will require an assessment from the nurse. Preterm labor, we give these people something called terbutaline. Terbutaline is a tocolytic drug, and it causes increased heart rate in both the mom and the baby. So prior to administering terbutaline, we always get a pulse from the mom, and we get a fetal heart tone. We will not administer terbutaline if the mom's heart rate is greater than 100. Terbutaline is a injection. We give it sub-Q. So just some nursing things that you have to know about terbutaline is that you got to always get that heart rate from mom. Normally what we will do is actually put mom on a pulse ox and monitor the baby's heart rate continuously while we're given this drug. Terbutaline relaxes smooth muscles and that's why it stops preterm labor. Our uterus is a smooth muscle, and so if we give people a drug that relaxes smooth muscle, then we can prevent the uterus from contracting. So you should know that that's a tocolytic and that we give it for preterm labor. Now, people with signs and symptoms of pregnancy-induced hypertension, so moms who are having high blood pressure, protein in the urine, those people will be treated with magnesium sulfate, IV. And MAG is also a drug that relaxes smooth muscles. So one of the big things with magnesium, whenever we administer that IV, is that we have to watch for toxicity. And if we see toxicity of MAG, signs and symptoms of toxicity, that's a big thing. We'll talk about that a little bit later. And then again, another danger sign of pregnancy are a severe increase or a decrease or no fetal movement. This is mom's the best indicator that the baby is doing well, normal fetal movement. If she experiences particularly a decrease or no fetal movement at all, it should be her first warning sign to come and get checked out, because that's mom's best predictor that the baby is doing well. All right, let's move on and talk about pregnant families who have special needs. Who are they? Well, pregnant teens, because they're children themselves. We've already talked about nutritionally they're a special group because they are continuing to grow themselves. So they need special nutrition, number one. Women who are over 35 years of age, these people are known as geriatric pregnancies. They have a different set of issues that we need to look at and be aware of so we can help mitigate problems for these people. Late pregnancy, people in their 30s, substance abusers, physically and mentally challenged people, and victims of trauma and abuse. These are all special groups that require extra assessment and extra consideration from us as nursing personnel. So, pregnant teens, they are at high risk for complications such as iron deficiency anemia because they go on fad diets. They don't eat enough protein. They don't eat at normal times of the day. Maybe they don't want to eat at all. Typically, they can be very underweight or very overweight. Just depends. They also have underdeveloped pelvic bones. Remember, these people are not finished growing yet. They are still maturing. So they're at risk for CPD, which stands for cephalopelvic disproportion. And people with CPD tend to not be able to deliver vaginally. So it's important for us to recognize that up front so that we can schedule them for a C-section if need be. Also, pregnant people and adolescents are at a great risk for pregnancy-induced hypertension. And the reason why they are at such a high risk for PIH is because they have an immature immune response. And somehow that translates into their body creating an environment where high blood pressure during pregnancy just tends to happen for whatever reason. So we have to really, really closely monitor adolescents for pregnancy-induced hypertension. I have a friend who delivered a child at 16 years old, and she ended up with severe preeclampsia. She never did become eclamptic, but she had severe preeclampsia and pregnancy-induced hypertension, and she was so swollen. She gained over 100 pounds during her pregnancy and ended up as a very high-risk pregnancy, having to deliver in Wilmington, ended up on magnesium to get her blood pressure down, had a really, really difficult time. So you really have to watch these guys for high blood pressure. They are at a greater risk to hemorrhage during delivery. So we have to watch that. They're at a greater risk for preterm labor, which results in low birth weight babies. A lot of the time, adolescents and pregnant teenagers get no prenatal care, or they get very late prenatal care for whatever reason. They're embarrassed to tell their parents. They don't know what to do. They don't even know they're pregnant. So that puts them at a greater risk for not having a healthy outcome for mom and baby. They also are at a greater risk for STDs. We know that adolescents tend to be highly sexually active, at least ones who can get pregnant are. If they have STDs, then more than likely they are not using contraceptives either. And so if they are infected with sexually transmitted diseases, those are things that we need to be aware of, and we need to treat with antibiotics to prevent harm to the fetus. Many pregnant teens have, the ones that we see, might have lack of family support. They could be runaways. And they are at risk for ineffective parenting because they're children themselves. So they have a knowledge deficit related to child care. We have to really, really do a lot of educating with these guys. And these people are very hard to educate because typically, remember about back to the beginning of the semester when we talked about development, these guys don't respond well to authority figures generally. So a huge host of issues that put pregnant people at a high risk for complications. Women with advancing age, they are also at risk for complications. They have decreased physical energy. They are career-oriented, so they do not get enough rest. They're typically trying to do everything. Pregnancy takes a big toll on your body. It causes you to be very tired. And the people who don't rest like they should tend to end up with complications. People who have an unbalanced diet because they're running around worrying about work or about other children. They're not resting well, so they're eating on the go. So they tend to miss some nutrients that they need to get. These people also fail to progress in labor. Their bodies are tired. Their uterus may not have the same type of contractility that it did at one time. Remember, as women continue to advance in age, we tend to lose estrogen. And what did we say about hormones and sex organs with the woman who is advancing in age? Those things tend to atrophy. So if our uterus has atrophied to a point that it doesn't have the same contractility that it did previously in life, then it's not going to go through labor quite as well, right? Contractions will not be as forceful. They will not open the cervix as well as they should. And these people will fail to progress in labor, meaning they will not dilate to a 10 in order to be able to deliver vaginally, which puts them at risk for a C-section. So there you go, more cesarean sections. Uterine atony, again, puts them at risk for hemorrhage and postpartum bleeding. If our uterus doesn't contract well during labor, then chances are it's not going to contract well after labor and delivery, which means that they are at risk to bleed. We have to be really careful when assessing these people whenever we're doing our bubble heat. Also, these people might have an unaccepted pregnancy. They second guess if this is really what I should have done, right? They're already terribly tired. They may have children who are adults already. This could have been a complete mistake. This could have been the woman with a tubal who had a bilateral tubal ligation, 15 years ago and is now pregnant again. These people have a lot of emotions typically surrounding a pregnancy, especially if they have adult children and it was unexpected. They are at a greater risk for genetic defects such as Down syndrome, and they really need to opt to have that maternal serum alpha-fetoprotein test, because it will help determine if there are any genetic defects or abnormalities, and then allow us to do some further testing. Now remember, when we talked about the quadruple screen test, this is one that will detect Down syndrome. And here's what we see if we have Down syndrome with the quadruple screen test. You will see an increased HCG, an increased inhibin, a decreased serum alpha-fetoprotein, and a decreased estriol. Now, this slide says increased estriol, but please be aware that I said decreased estriol. This is a mistake in the slide, okay? So Down syndrome, you should see increased HCG, increased inhibin, decreased serum alpha-fetoprotein, and decreased estriol. Don't get that mixed up. Change that on your slide, and I will try to change it as well. These people also are at risk for infertility or multi-fetal pregnancies as a result of in vitro fertilization. So the woman with advancing age, this could be the lady who decided to not get pregnant until later in life and now is having an issue with infertility, not being able to get pregnant, possibly due to her advancing age. And so she goes through rounds of in vitro fertilization and then ends up with twins or triplets. And think back to all of these complications and risk for complications that we've already talked about, and then add a multi-fetal pregnancy on top of that, and you can imagine how high risk this particular individual would be and would require a lot of close following. These ladies are also at risk for cancers. They are also at risk for pregnancy-induced hypertension. Very young people and older people are really at risk for that pregnancy-induced hypertension, preeclampsia. And varicosities. Think back to that picture when we talked about integumentary changes in women during pregnancy, and think about that picture of varicosities. These people with advancing age that get pregnant are really at risk for those. All right. How about the woman with motor and or sensory deficits? Imagine being the labor nurse for that person. So you're talking about people that can be blind, deaf, have spinal cord disorders. These people are unable to see, maybe hear or feel, so we have to be very, very stringent about making sure we keep a safe environment for these people and tell them what is going on. If they can't see or they can't hear, you can imagine how terrifying going through the labor process or even the prenatal period can be to these individuals. We really have to do a good job at keeping them safe. And then we may need to use special equipment so that we can have a user-friendly environment for these people. We have to modify our care to accommodate their handicap because they need lots and lots of assistance. If they're on any type of prescribed medications, we need to be making sure that they continue those as long as they're safe for the pregnancy, and we need to be working with their other healthcare providers if they have specialists involved in their care, to make sure that we can change medications if we need to. For example, if one is not safe for the pregnancy, maybe getting it switched to one that will be safe for the pregnancy. We need to modify communication media that we use in order to be able to take care of these people more appropriately. We can use touch, visual aids, and audio. And for these people, breastfeeding really is ideal. I know we talk about breastfeeding being ideal for other people as well, and it is. But the people who have motor and sensory deficits, blind and deaf people, breastfeeding really is ideal because it's there, right? It's there, and it's in the right amount, and it's the right temperature, and they don't have to go through the process of making bottles, measuring out formula. So really breastfeeding, if we can promote that and help them to be successful at it before they go home, it really, really makes their life a lot easier. Women who are emotionally and physically battered also are at high risk during pregnancy. They tend to delay prenatal care because they don't want anybody to know what their situation is, or their significant other will not allow them to get prenatal care. These people miss appointments. They might abuse drugs and alcohol. They suffer emotional and physical trauma, usually that can be overt enough you can find on assessments. And they are very socially isolated people. They require you to be very on top of your assessment skills to pick up on these things sometimes. And these are some of the women that you want to schedule to come back for appointments as often as necessary so that we can be sure that both mom and baby are staying safe. These are individuals we might want to refer to Families First or refer to the battered women shelter to give them access to resources, or make sure that they know about resources in their community close by that they can access and know how to access to get out of any of the situations that they may be in. These people are at risk for abruptions. If they are physically battered women and their significant others are pushing them down or hitting them in the stomach or, physically abusing them in a way to where they receive some type of blow to the stomach, they're at risk for abrupting, and then they're at risk for bleeding out and for the baby not surviving. So we really have to concentrate and pay really close attention to these types of individuals. All right, moving on to the substance abuser. This is also a special population, super special population, and they put themselves at high risk for a lot of different things. This is a terrible picture, and it gets me every time, but this is a baby whose mom was a substance abuser, and you can see the terrible things that it has done to this child in terms of physical abnormalities. and I'm sure there are lots of other abnormalities not shown in this picture, but I mean, just completely, I can't even say it because it's not appropriate to say on this PowerPoint. So anything, and even over-the-counter medications that are not approved for pregnant women really need to be looked at very closely before being consumed by pregnant individuals. Cocaine gives a very high risk, puts these ladies at a very high risk for placental abruption. And that's the one drug that will cause women to abrupt quicker than anything else. So if you know that you are taking care of a mom who is a cocaine abuser, we really have to educate her about the signs of placental abruption, because typically these are the ones that you will see in terms of substance abusers. These are the ones that you see come into the facility abrupted, or cocaine users. Marijuana, opiates, amphetamines, PCP, caffeine, alcohol, and ecstasy all are a list of substances that we see frequently. Now we're tending to see a lot of heroin addicts, and especially different types of narcotics like Percocet, and those type of drugs. So what does it do to mom? Well, if she comes into the hospital and she can't access her drugs, then she may start going through withdrawal. And withdrawal can be very dangerous to the fetus. So we have to be very, it can be dangerous to the mom as well, but it can also be very dangerous to the fetus. So we have to pay close attention to moms who come in that are substance abusers and mitigate and manage any type of withdrawal symptoms. We have to be able to recognize them first and mitigate any bad outcome. Alcohol withdrawal, you typically are going to see within 12 to 48 hours, and we all know that alcohol withdrawal can cause seizures, central nervous system signs and symptoms, so we really have to pay close attention to those people who are drinkers. These people are typically at a higher risk for STDs. They are at higher risk for myocardial infarctions, preterm labor. There again, abruptio placentis, especially with cocaine. Other drugs can also cause placental abruptions, but cocaine is that main one. These people are at risk for malnutrition and nutritional deficits in general, because they tend to do drugs or drink alcohol instead of eating and nourishing themselves. And a lot of times you may find these people are coming in to you from the jail because they are imprisoned for different types of criminal charges regarding their substance abuse. So what does it do to the baby? Well, with drugs, babies tend to experience those withdrawal symptoms in 6 to 12 hours or within 3 days. These babies can experience congenital malformations like you saw on that first slide, preterm labor, which will in turn produce a low birth weight fetus. These babies will be small for gestational age, and some of them may experience death due to uteroplacental insufficiency. Trauma and treatment during pregnancy. So let's think about some of the different types of trauma that you might find happen to pregnant women. Motor vehicle crashes, homicides, suicides, orthopedic injuries from falls, poisonings, intimate partner abuse, wounds and burns, are all different types of traumas you might see during pregnancy. So motor vehicle crashes can cause direct blunt force trauma to the abdomen, and we know that can cause placental abruptions. People with placental abruptions tend to hemorrhage, and the babies tend to experience asphyxiation due to uteroplacental insufficiency. So these individuals will die very quickly if they are not managed fast and appropriately. Homicide, obviously, that's not a good outcome for mom or baby. Suicide, same thing. Orthopedic injuries from falls. Remember that our musculoskeletal system changes during pregnancy. Women experience lordosis. Their center of gravity shifts. They tend to be very off balance. They're carrying a whole lot of weight out front, and that they can't see their feet, right? They can't see where they're walking. So they might experience different types of orthopedic injuries from falling. Poisonings can happen from over-the-counter medications. Poisonings can happen from environmental, different types of environmental exposures, or from substance abuses. So you might see overdoses. Intimate partner abuse can also have an outcome of blunt force trauma to the abdomen. And then, of course, wounds and burns are self-explanatory. So how do we manage these things, this trauma, and how do we treat it during pregnancy? Well, depending on what it is, we have a few different things that we can do. First of all, we want to prevent it if possible. So we want to teach people to wear their seat belts. We want to teach them to get out of abusive relationships if possible. If they have depression, we want to treat depression and catch suicidal tendencies early. We want to teach them ways to prevent themselves from falling. If they come in and they've had some kind of trauma happen, then we've got to treat the shock, okay? Ephedrine will help increase heart rate, help increase blood pressure. That helps to treat people who are coming in with hypovolemic shock from things like a placental abruption. They may need dopamine, oxygen. We want to monitor the fetus and the mom during this trauma and treatment for it, and prevent infection as well, typically with antibiotics and standard precautions.